In our first presentation on the possibility of institutionalizing active euthanasia or physician-assisted suicide, we looked at some of the concerns that people have raised about such a policy, independent of the idea of whether or not an act of voluntary active euthanasia or physician-assisted suicide is ever justified. We looked at the concerns about adverse social consequences. We also considered the possibility of abuse, to which John Eris has pointed most forcefully and notably. In this presentation, we want to look at two different proposals for regulating the practice of voluntary active euthanasia and physician-assisted suicide, asking whether these regulations could create a policy framework to allow certain cases of voluntary active euthanasia or physician-assisted suicide while preventing the sort of adverse social consequences or abuses about which people like Eris are concerned. Let's look at these two proposals. The first policy we will consider is one that's outlined on page 212 and following in your spiral textbook by Timothy Quill, Christine Castle, and Diane Meyer. The first thing you should notice about their proposal is that it is limited to physician-assisted suicide. But let's consider the further limits they would place on a practice of physician-assisted suicide. First, they envision a policy that is limited to patients who are incurable. That is to say, they have a terminal illness that cannot be alleviated. Secondly, they must be experiencing severe and unrelenting suffering, which is not the result of inadequate comfort care. So first, we want to try better comfort care. Third, they would insist that any administration of physician-assisted suicide must come after a repeated, freely given request from a patient whose judgment is undistorted by pain, undistorted by coercion, undistorted by a misunderstanding of their situation. They must ask for physician-assisted suicide several times or repeatedly. And this request must be in the context of a meaningful doctor-patient relationship. What Quill and his colleagues are concerned about is that we not set up a policy where specialists in physician-assisted suicide would accept patients. Rather, what they envision is a situation in which your regular general practitioner, possibly, is that person to whom you go for physician-assisted suicide. Finally, they would require that any administration of physician-assisted suicide be on the basis of a second opinion of another physician who verifies that the patient is incurable, that they are experiencing unmanageable suffering, and that their request has been repeated and is uncoerced or truly voluntary. So that is Timothy Quill and one set of colleagues' attempt to put in place a proposal to approve the legalization and institutionalization of physician-assisted suicide, but to limit it in significant ways so as to prevent the adverse social consequences and the subtle coercion that folks like Eris are concerned about. Quill is a part of another group, and I think Diane Meyer is also part of this group, that includes a man that I once worked with, John Fletcher, who was the head of the Center for Biomedical Ethics in the University of Virginia Hospital. Their proposal for a more complex proposal for regulating physician-assisted suicide begins on page 220 in your spiral textbook. Let's look at what Miller and his colleagues, including John Fletcher, propose. The first thing I would ask you to notice is their account of why there's a need to regulate the practice. They acknowledge that the practice of physician-assisted death lies outside of standard medical practice, and they acknowledge the possibility of abuse. The other thing you should notice is that they use the language of physician-assisted death and mean that to include both physician-assisted suicide and voluntary active euthanasia. Finally, I want to draw your attention to page 22 in the right-hand column, their list of the objectives of any regulatory policy. Pay attention to the 6 objectives that they name there. Now, they say physician-assisted death should only be available to incurable patients, patients whose diseases cannot be cured or reversed. But they would not require that the patient be terminally ill, that is to say that they be in the process of dying. They suggest that only adults with decision-making capacity should be allowed to seek physician-assisted death. They don't specify whether that could be by advance directive. That is to say, could you ask for physician-assisted death while in a state of capacity, but it be applied after you have lost that capacity. Notice, please, their concern to protect the conscience of physicians. No physician, they say, would be obligated to participate in the practice of physician-assisted death. They have in mind physicians who obviously have some kind of moral objection to the practice. Now, one of the most interesting aspects of this proposal is their palliative care consultants and a palliative care committee. One of the first things that's interesting about this is this emphasis on palliative care. Of course, a big concern about any proposal for physician-assisted suicide or voluntary active euthanasia is that it will undermine our concern about end-of-life care, particularly the treatment of pain and suffering. They show their concern about this by insisting that no patient may receive assistance in suicide or voluntary active euthanasia except in consultation with a fully trained palliative care consultant who is an expert in treating pain and an expert in verifying that the best has been done to assure that patient's pain and suffering is treated as well as possible. And then there are these palliative care committees to which they refer that oversee the entire process. You can see the consultants described on page 223, starting on the left-hand column and moving into the right. But let's look at what the palliative care committees will do. It will be their responsibility to develop, issue, and revise the guidelines for these practices. They'll train the consultants. They'll be responsible to educate the public about, and healthcare professionals, about the processes for physician-assisted suicide and voluntary active euthanasia. And they will be a sort of consultation committee. Most significantly, maybe, they will review all cases after the fact, in part to make sure that concerns about abuse are addressed or are not a factor in these situations. I will conclude my discussion of the practice of physician-assisted suicide with a brief account of a paper by Courtney Campbell related to the experience with physician-assisted suicide in Oregon. Courtney and I were in PhD work together at the University of Virginia many years ago, and I heard him give this paper and this report on the experience in Oregon several years ago on a visit to the University of Virginia. I think Courtney's report is particularly interesting because Courtney himself is very, very involved in the hospice movement in Oregon, and also tends to be very skeptical of the practice of physician-assisted suicide or voluntary active euthanasia. And yet this report is relatively positive with respect to what has happened in Oregon. I think the fact that this positive report comes from the work of a person who tends to be skeptical about the practice lends it even greater weight. So let's look at some of the findings of Courtney Campbell in this paper. Shown here is Campbell's account of the rationale for the Oregon Death with Dignity Act. And you can see its emphasis on extending patient self-determination. But what I want us to focus on is Courtney Campbell's account of what he calls the unexpected result of the experiment with physician-assisted suicide in Oregon. The first thing he notes is just how few patients have actually asked for this assistance. In the 10 years that he studied, the first 10 years, there were only 541 prescriptions written, and only 341 patients actually took the drug. He notes that despite the predictions of many others, only a very few states have actually followed the Oregon example. He also notes that it seems that patients have not referred to motivations that suggest some kind of coercive influence. They haven't named things like finances or being a burden as things that induced them or motivated them to opt for physician-assisted suicide. As I'm suggesting, or as Courtney Campbell suggests, this indicates they aren't choosing under duress, but it really does represent what those patients have wanted, probably. He's noted that the practice has become widely accepted in Oregon. There's not a great deal of resistance to it or opposition to it. It seems to have become an accepted part of ordinary medical practice. And then finally, and this is most interesting, palliative care and pain control have emerged, he says, as a paramount focus of end-of-life care since the introduction of physician-assisted suicide in Oregon. So let's understand what this means. I mean, one of the concerns has been that any policy or practice of physician-assisted suicide would undermine incentives for palliative care. And what he found was exactly the opposite. That, as a matter of fact, greater attention has been devoted to palliative care in Oregon since the passage of the Act than existed previously. Now, as I indicated at the beginning, Courtney Campbell tends to be opposed to the practice of physician-assisted suicide or voluntary active euthanasia. And as you might expect then, despite the surprising results he found, he does think there are some unanswered questions and some ongoing concerns related to the practice of putting patients to death in Oregon. The first thing he worries about is the true nature of the patient's experience. Remember when we talked about the evidence that patients are not choosing physician-assisted suicide under financial pressure or a fear of being a burden to their families, suggesting, Campbell says, that they are not under duress, that this truly is their choice. The problem is that information is based upon the report of physicians who on a form they have to fill out in relation to every patient that they help assist in whose suicide they assist. The physician fills this out on a form and checks off a list of motivations. So this is really second-hand information. It is information on a form that already has listed possible motivations. So Campbell is suggesting we may not know as much as we think or as much as we'd like about the actual nature of the patient's experience and of course, most importantly, their motivation. Some deeper, more philosophical issues that Campbell raises have to do with the very idea of a dignified death. It's called the Death with Dignity Act, and he raises questions about what we mean by a dignified death, and whether the idea that simply a death without suffering is a sufficient understanding of what it truly means to die with dignity. And then finally, he raises an issue about which I have spoken a bit throughout this course, is the whole question of physician integrity and their sense of vocation, you might say, in their craft, in their job, in their role as a healthcare provider. How does the practice of physician-assisted suicide affect the physician's sense of himself or herself as a healthcare provider? Still, I think overall we must say that Campbell's report and reflections are relatively positive in relation to the experience in Oregon. And hopefully all of this will help you think more deeply about what you believe policies ought to be in our state or in the state in which you live in relation to physician-assisted suicide or voluntary active euthanasia.